All right, guys, we're going to go ahead and get started here. I'm going to get my screen turned around so you guys can see this really quickly because we've got some ground to cover tonight, and I don't want to make it a really late night for you guys, especially with the material that we're going over. All right, you guys able to see my PowerPoint?
Yep.
Perfect. So tonight we're going to start to dip our toes into 12 leads. You know, we've gone over basic rhythms. We've gone over the basic concepts of what it makes up a rhythm, such as your P wave, your QRS, your T wave, your normal PR intervals, your normal QRS intervals. So tonight we're going to look at some of the things that we really look for when it comes to performing a 12 lead and why we really perform a 12 lead and what exactly we're looking for. Now, this is a very, I don't want to say quick process. Once you've been doing it a while, you can look at a 12 lead and read it pretty quickly, but it takes a lot of time to learn which order you're going to read a 12 lead in. So please don't feel like you are going to learn it all in one night. I don't want you guys to feel like that is the case at all. I want to make sure that you guys understand it before you get too lost in it. And trust me, there are going to be times when you understand things. There's going to be times where you don't understand things. And that's okay because you have a lot of ground to cover before you're done with paramedic school. Our internet's been kind of shady here at the college, so if for some reason the PowerPoint you aren't able to see it or something like that, please let me know as I'm going, just so that way I can stop and get things fixed. They've been updating our Wi-Fi and routers and everything at the college, so just want to make sure that everything is still working out. So looking into 12 leads, what are some reasons we perform 12 leads on patients? What's a big reason we perform 12 leads on patients?
Because you can actually see ST of elevation or depression to see if they're having.
Okay, so
see the rates, the rhythms, and where they're firing, and there might be a problem with the electrical system.
You mentioned ST elevation and ST depression. What conditions do those relate to when we talk about ST elevation or ST depression? Because that's really something we see on a 12 lead. It's not essentially what we're putting a 12 lead on for. That's something we can look for, but what is a big reason we do a 12 lead on patients? What's the chief complaint?
Chest pain for an MRI.
Chest pain, right? That's one of the most common reasons we do a 12 lead. We can also do a 12 lead for weakness, shortness of breath, dizziness, nausea and vomiting, anything that can essentially be related back to cardiac. Back pain, stomach pain, heartburn. These are all reasons we should be performing a 12 lead. Now, a 12 lead goes above and beyond just your basic rhythms. You need to understand how to interpret a basic rhythm before we look into 12 leads. You need to know what a normal sinus rhythm is. You need to know what sinus tach is, what sinus brady is, because we are tonight going to talk about ST elevation and depression. And that's the majority of what we're going to cover tonight because it is a majority of what 12 leads are. Pertaining to the foundation of paramedic education. In the next couple weeks, we'll talk about different aspects of 12 leads as well, but this is a bread and butter of why we perform a 12 lead on somebody. So our objectives for tonight, be able to recognize and localize potentially where an MI is occurring on an EKG, more specifically on a 12 lead. Develop your own method, and I'm not saying the way I teach you guys is the only way. Everybody looks at 12 leads differently. How I looked at 12 leads 5 years ago has changed to how I look at them now. It's just that develops with time and how you constantly are looking at 12 leads in accordance with what you're performing for a job. At some point, we'll talk about going a little bit further than 12 leads, but for now, we're going to stick with the basic knowledge, okay? What is an MI? We have to understand what an MI is and what's truly happening to know what we're looking for in 12 leads. So what is an MI?
A blockage preventing oxygen from getting to the heart.
Okay, some sort of blockage preventing blood flow and oxygen from getting to the heart. So when that happens, we can see on a 12 lead what's called ischemia or hypoxia, if you will. Same term, just a different, being used differently. So it's lack of oxygen to the muscle, right? We know that muscles need oxygen to perform their job, and we know that they need blood flow to perform their job. Our heart is no different. They are nothing but a muscle, right? Now, if there's reduced blood supply to that muscle, it can become injured. Just like our brain, reduced oxygen to our brain over a period of time can cause injury. First, our brain becomes hypoxic. If not corrected, it becomes injured. The same with our heart. It becomes ischemic due to a possible blockage. Most of the time, it's due to plaque buildup, due to like hardening of the arteries, and then it leads to injury if left untreated. So the term MI stands for myocardial infarction. In layman's terms, it's a heart attack, right? That's what we are looking for when we're looking at a 12 lead. And if any point you have questions during this, please ask questions, because again, you can get really behind really easily. When we look at a 12 lead, and this is an older version of a 12 lead, but very similar to what we see now, we're looking primarily at this top strip here, okay? It consists of different leads, right? 12 different leads to be specific. We got lead 1, lead 2, lead 3 on the left column. To the right of that, we have AVR, AVL, and AVF. To the right of that, we have V1 through V6. V1 through V6 sounds pretty familiar to us, right? When we assist in putting 12 leads on. So those are what are called precordial leads. And that means the ones that go on the chest of our patients. As opposed to 1, 2, 3, AVL, and AVF, that's what you're putting on when you're essentially putting on a 5 lead. When you're doing it in the hospitals now, is you're looking at limb leads. That's to determine a basic rhythm, right? So precordial leads are always on the right. You can divide it in half like this. Precordial leads are on the right, limb leads are on the left. So we'll label this limb, and we'll label this just PRE for precordial. Now, when we look at a 12 lead, the initial lead we should be looking at to determine the rhythm is lead 2. And that's the same as what we're looking at on a 3 or 4 lead. We look at lead 2. A lot of times this will print off on the bottom, depending what monitor you're using. But looking at lead 2 right there, if based on what we know about basic rhythms, if you were to look at that, and that's generally a 3-second period of time, what would you say my rate is if that was 6 seconds? If that's 3, multiply that by 2, what would my rate be?
60.
Okay, around 60. Monitor saying around 66 if you look up towards the top. So we're not far off. Okay, now what would you classify that rhythm as? Look to see if it's got a P wave, look to see if it's a narrow QRS, and look to see if we do have a T wave.
You have P waves in each one. Your rhythms are marching around the same way, so it's normal sinus.
Okay, I would agree with that. Also, in a lot of times we don't have to say normal. We can call it a sinus rhythm, but yeah, we can call it NSR. And that's what the monitor says as well. If you look up at the top, normal sinus rhythm. It also tells me it is a normal EKG because I don't see any abnormalities on this. Looking at this really quickly, how I start to look at a 12 lead, and this is before I'm teaching you guys any abnormalities or anything, is I start with lead 1 up here. This is where I start looking. And then I travel in this direction. So I'm looking literally, not sideways, not down. I'm going diagonal towards V6. Because as I'm doing that, I'm able to see all the leads when I'm looking at them, if that makes sense. Some people choose to start here and go down, and then look over here and go down, and then look over here and go down, and then following this as well. And that's fine. That's completely up to you. It's really your preference on how you want to look at a 12 lead. There is no right or wrong way. I just happen to look at the whole thing at once, and if I see something abnormal that catches my eye, then I focus in on it. Looking through all these leads here, is there anything scary that sticks out just from your knowledge that you have now? Look at all your leads, every single lead on here. Do you see P waves? Do you see QRSs? Do you see T waves?
Yes.
Yeah, nothing sticks out to me, right? They all look pretty uniform. It all looks pretty much the same. I have no concern with this. Monitors will also give you a lot of information here at the top, such as numbers. PR interval is 172. That translates to 0.17. QRS duration is 96. That translates to 0.09 or 0.10, whatever you want to say. So within normal limits. Those are the two numbers I want you paying attention to right now. PR interval and QRS duration. Now, some rhythm strips, let me make sure I've got the right, yep. Some rhythm strips will tell you and confirm what you already believe. The problem is not all monitors are very good at what they do. They're not very good. They can't say, okay, if it sees, let's just say, it sees elevation in a lead. That elevation could be because the patient moved at the wrong time and it picked up on it, and it could say this patient's having a heart attack. What monitors are really, really good at is telling you these numbers. They are very good at telling these numbers. These numbers are very truthful when it comes to monitor interpretation. This up here that's circled with the arrow, not so much. Sometimes monitors get confused. They might spit out the wrong information based off of what it's seeing. So always, I'm going to teach you to always rely on your manual interpretation, not just what the monitor says. Treat your patient, not the monitor. And I know I've said that I don't know how many times, and I'll continue to say it. Use your manual skills and what you will learn as a paramedic to identify what you see with the patient, not based off of what a piece of technology tells you. Again, intervals and durations. The ones I want you paying attention to when we're looking at 12 leads right now is PR interval and QRS duration. Those two. They will always print out in milliseconds. All you have to convert that to is seconds. So 172, again, equals 0.17. 96, if I round up, equals 0.10. What's my normal PR interval range?
.12 to 0.20.
0.12 to 0.20. So I'm within normal limits there at 0.17. What's my normal QRS range?
0.04 to 0.12.
Nope, close. And you're not
Okay.
you're not off. You can say that. Generally 0.08
Okay, I read that wrong, sorry.
to 0.12 is our normal range. So again, I'm within normal limits there, so nothing concerning jumps out to me. How you convert your milliseconds to seconds. Okay, when looking at these leads, we need to memorize the placement of this. We need to memorize that 1, 2, 3 will always be in this order. AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. That's pretty standard. That's really easy to memorize. The next part I'm going to show you is very hard for paramedics to grasp, especially going through paramedic school. And it pertains to what part of the heart those look at. So, starting with lead 1. It looks at the lateral portion of your heart. Lead 2 looks at inferior. When we say inferior, I want you to imagine right side. So for all these inferior ones, I'm going to put an R next to them for right side. Lead 3 is also inferior. Lead AVR, when it comes to 12 leads, I do not want you paying attention to AVR. AVR is just a reversed lead. That's it. Nothing else. It will not show elevation. It will not show depression. So when it comes to AVR, that lead means nothing. Lead AVL is also a lateral lead. Lead AVF, inferior. V1 septal, V2 septal, V3 anterior, V4 anterior, V5 lateral, and V6 lateral. So what that means is that 1 in AVL, along with V5 and V6, look at the same part of the heart. Those 4 leads make up our lateral leads. So when I talk about an abnormality, if I have an abnormality in lead 1, I automatically look to lead 2, or lead AVL, sorry, to see if the abnormality is mirrored there. Then I will look at V5 and V6 to see if it's mirrored there as well. The same for all my other leads, 2, 3, and AVF, my inferior leads. If I have an abnormality in 2, I look at 3 and AVF to see if it's mirrored. Same with V1 and V2 because they're septal. Abnormality, I look in the other one, as well as my interior of V3 and V4. I believe I have this uploaded on D2L for you guys to keep, because this is very important that you either carry with you during your clinicals or during your ride time. I cannot express how important this is for you to know as paramedics. If you cannot grasp what part of the heart's leads look at, you could be in a world of hurt when it comes to 12 leads. And I'm not saying you have to remember it tonight. I'm not saying you have to remember it next week. But by the end of the semester, you should be able to tell me what leads look at what part of the heart. I'm going to hop over that for a second. Q waves, we know a little bit about. We know that it is essentially our atrial repolarization, where our SA node is resetting. But if we have a Q wave that is greater than 0.04, so one small box measured as such, that can indicate a prior heart attack that a patient has had. It is called a pathologic Q wave. So when they have a wide or deep Q wave, it could indicate a potential prior heart attack that the patient has had. Do I pay a lot of attention to that? No. Because the patient will generally tell me if they've had a prior heart attack. But it is something you can see on a 12 lead. When we're looking at a rhythm, I'm going to label some of this stuff. P wave, Q, R, S, and T. Where our S wave begins to come back up to baseline, that corner is called a J point. Why a J point is important is because that's where we look for elevation. That is the point that we look at for elevation, no matter what lead we're looking at. That point is always going to be the same. And what we're looking for is elevation throughout this ST segment. Hence the term ST elevation, if you ever heard that, or STE. Another example where I start to come back to baseline is my J point. This is my ST segment. When I am measuring elevation, I am comparing this to the period either here or after my T wave. I want to know if it is elevated above that normal line. So please remember J point. Some examples. Let's look at A up here on top left. That is a normal J point. As you can see, our wave went down, came back up. Where we start to curve, where we start to change directions, is our J point. Let's look at B. Came down, where we start to turn directions towards our T wave, that's our J point. J point is here, where we're starting to change directions. Here. And here. Now, when we start to talk about ST elevation, this is a perfect example of what I'm looking for. Let's look at B here. Anytime we have 1 millimeter or more of ST elevation, or elevation above the baseline, we can call that potential injury. Okay, so baseline is here, where I'm drawing this line, right? That's baseline. Where that J point is, how many millimeters of elevation do I have over baseline?
Two.
Yeah, 2 millimeters, right? Remember, one small box equals 1 millimeter. Okay, looking at C. And I'm going to call on somebody random because I want to make sure everybody grasps this. Let's see who I got in this class. Mr. Leach. How much elevation would you say is there above baseline in C?
I'd say 1.
Okay, 1, maybe slightly over 1, I would agree. Okay, somebody else, I'm not going to pull that back up because it takes away the screen share. Somebody else, we're going to call this, we're going to look at D. Here's baseline. Is my J point elevated above baseline?
No.
No.
Okay, so if it's not elevated, then what is it?
You have depression.
I have depression. Okay, depression indicates ischemia. That is basically hypoxia going to the heart. That is a precursor to somebody having a heart attack. If I generally see that on a 12 lead, I can expect by the time I get to the hospital, I will start to see elevation. All right, letter E, somebody else. How many am I elevated over baseline here?
Three.
Okay, I'd say 2. I've got 1 box. I've got 2 boxes. Right here is my J point. And remember, anything above 1 millimeter can be called elevation. Anything less than 1 could just be like stress in the heart, like somebody just got done exercising or something like that. Their vessels are constricted, they have reduced blood supply. Anything greater than 1 is more of a concern. Remember, if I'm looking at this, my J point is where I start to change direction. So right here would be my J point. And then this is my ST segment, in between my S wave and my T wave. Kind of like my PR, except that one's labeled ST. Now, again, I keep hitting this home because I want you guys to get a grasp on this. I compare this segment, my ST segment, to either my TP segment here or my TP segment here. An easy way that I even talked to the last paramedic class to look at elevation is to literally draw this line straight across. And am I elevated or depressed across that line? Just to get you guys in the habit of looking for elevation or depression. Some of these pictures are kind of blurry, and I do that for a reason. Because when you take tests, just like your EKG packets that I've handed out to some of you, your pictures are not always clear. And they do that because they want you to actually look for some landmarks here. Okay. So I'm going to help you guys out here. I'm going to put some numbers on here, and I want you to tell me which one is the J point. Okay.
Is it 3?
It is 3, right where I start to change directions, right there. Okay. Now, ST segment, right here, in between my S wave and my T wave. Looking at that, do you see any elevation? Remember, this is baseline.
Not really, no.
No, that doesn't really concern me. Okay, let's find the J point again. Which one's my J point?
2.
2, okay. There's my J point. Now let's find baseline. What do you guys think?
You have elevation. I'd say like 1 to 2. I can't really tell. There's no points. So.
It'd be a lot more than, it's almost like 5.
Okay, it's hard because there's no like numbers to look.
But remember, one of these big boxes is 5 tall. A big box is 5 across and 5 tall. So that would be close to 5 millimeters of elevation. That is potentially a massive heart attack that this patient is having. And again, I understand the pictures kind of suck. This one, again, very blurry picture. Let's find our J point.
So that one's depression. Like
Okay, where's my J point though?
right after the 3.
Okay,
Except,
what number is that?
1.
1.
oh, sorry. 1.
There's my baseline. I would consider that probably a millimeter of a depression, indicating potential ischemia. What about here? Let's do. Where's my J point?
5.
5.
Okay. Baseline. Anything too concerning or no?
Not really. Slight
No.
depression.
And don't. And here's the thing I will say about when you're looking for depression or elevation: don't talk yourself into seeing something you don't, because you'll go down a rabbit hole of thinking something's wrong with your patient that isn't. Anything that is, and again, when I'm looking for elevation depression, there's still some stuff I have to teach you. There's what's called contiguous leads, which I'll get to here shortly, but I want you that word to stick in your mind: contiguous leads.
Rudy?
Yeah.
Would this be something we see all the way across the strip, or just is it going to be consistent, or something we look for intermittently?
In one lead, it could be consistent, but not in the next lead. Because remember, those leads are looking at different parts of the heart. So different parts of the hearts means different arteries. Those different coronary arteries, your right, your left circumflex. These are all little camera angles looking at your heart. So you could have elevation or depression just in one lead, or 2 leads, or 3 leads, but you're not going to have it in all of them. Which I'll get to here shortly. Found a couple of these. Let me move on. All right. So I kind of jumped ahead of myself and taught you guys some stuff. Normal J point here. Normal ST segment, non-elevated. If I look to the picture to the right, the ST elevation, J point. Baseline is right here. I've got about a millimeter of elevation above baseline. That's pretty simple, right? Is anybody confused on that or need some further explanation on elevation? Okay, moving on. Anytime we see elevation above baseline, just like this, I want you to think injury. We're past the ischemia stage at that point, okay? Anytime you see depression, I want you to think ischemia. Injury for elevation, ischemia for depression. So when it comes to looking for a potential MI, we need to know what we're looking for. And in this case, when we're looking for an MI, we are looking for ST elevation or depression. But where? Here's the key word. Where are we going to be looking for it at? And honestly, it's wherever you see it at. I know that sounds stupid right now, but when I show you a 12 lead that potentially has elevation, I'm going to show you how it can be in 2 contiguous leads. So let me back up real quick because I want you guys to all take a picture of your screen when I pull something up. All right, everybody in this class, I want you to take a picture of this right now, so that way you guys can use it here shortly when we're looking at different leads. And I want you to keep this in your phone as well for something you can refer back to.
Rudy, can you go back to the picture where you showed the ST depression where you said injury or ischemia?
Yeah, after everybody gets
Thank
this
you.
picture taken, I will.
Yep, thank you. I was trying to write it down, just flipped too fast.
Does anybody not have this picture yet? All right, moving on. Were you talking about, let me see, the slide?
Yes, thank
Okay.
you.
Let me know when you're finished.
I'm good, thank you.
Okay, when I say this word, or these words, contiguous and leads, what that means is if you look at that picture that I had you take, that's leads that look at the same portion of the heart. Leads 1 in AVL look at lateral along with V5 and V6. Those are contiguous leads, meaning they look at the same portion. When you think contiguous, think of the same portion of the heart. 2, 3, and AVF are contiguous leads. V1, V2 are contiguous leads, and V3 and V4 are contiguous leads as well. So let's look at this strip here. Again, let's start looking at one. Let's go down. So start looking at lead 1. Let me see if I can zoom in on this a little bit. I don't think I can. Oh, there it is. Okay, lead 1. Do you see elevation or depression at that J point?
Depression.
Okay. So when I see depression, especially this early on, that tells me there's ischemia, right? There's a reduced blood supply to one of the arteries in the heart. When I see ischemia, that gives me relatively high level of caution that somewhere in this 12 lead, there's probably going to be elevation. Now, lead 1 in AVL, look at that picture that I had you guys take a picture of. What part of the heart do lead 1 and AVL look at?
The lateral.
Okay. So they're contiguous then because they look at the same part of the heart. I want you to jump over to AVL right there. What do you also see in that lead?
Sorry, elevation.
Are you sure?
Wait, sorry, depression. Sorry, I had to look back.
Okay, depression.
Yes.
So I know in those contiguous leads, I have depression. They're looking at the same part of the heart. I now know that that coronary artery, whatever it's looking at, potentially has a blockage, reducing blood supply. So I'm going to keep going down from lead 1 to lead 2. What do I see in lead 2?
Elevation.
Okay. Lead 2, lead 3, lead AVF are contiguous leads. So I want you to look at 2, 3, and AVF. What do you see in all 3 of those?
Elevation.
Okay. Now let me zoom out. If I can figure out how to zoom out here. Okay. Now looking at this 12 lead overall, I want you to tell me where you see depression.
One LV. Okay. 1 ALV.
AVL.
Lateral and septal lead.
Okay. When you say septal, what leads are you referring to?
That would be 1 and 2.
Okay.
V1 and 2.
So let's look at lead V1 and V2. Do you truly see any depression there?
No.
Okay. And that I bring that up for a reason. Okay, so do we really see any other depression besides 1 in AVL?
Nope.
Okay. Now what leads do I have elevation?
All besides V1 and V2.
For
For the rest of
elevation?
them.
Okay, call out a lead and we'll look at it.
2 or 3 AVF.
Yep. Yep, and that's clear as day elevation. If I was to draw baseline on those, here, there's AVF, there's 2. We're elevated above baseline. A good 2 to 3 millimeters in each lead. Where else do you see elevation?
V3, V4, V5, V6.
Okay, let's zoom in on those. Do you truly see elevation in those?
Nope.
Oh,
No.
no, maybe not.
What you're seeing is that tall T wave that's starting to slope up. That's what's called a hyperacute T wave. And that is a precursor to an MI as well. And we're going to go over that here shortly. So, elevation. I only see in leads 2, 3, and AVF. Would you guys concur?
Yes.
Okay.
Well, the first one in 1.
That's elevation?
No, sorry. 1 depression.
Okay, there we go.
1.
So 1 AVL, I've
L.
got depression, right? Goes down.
Correct.
So if I was looking at this and I was going to call a STEMI alert, which you can, anytime you have elevation with depression in other leads, you can call a STEMI on that because that is a really good indicator this patient is truly having an MI. Although we don't have an angiogram, we can't truly tell. We can only go off of our knowledge. If I was to say this person was having an MI in a certain part of their heart, what part of the heart would you say is having a STEMI?
These-
Say inferior.
Yeah. This thing would print off generally and have the little stars next to it and say STEMI, and it would generally say inferior. If I was going to call a STEMI on this and not using Pulsar or any of that, say I'm calling the hospital, I would say, here's my patient, here's what's going on. We performed a 12 lead on this patient. I do have ST elevation of 2 to 3 millimeters and leads 2, 3 in AVF with, and the key word here is reciprocal. Reciprocal means where I have elevation, I have depression in other leads. So I have reciprocal changes in one in AVL. That means I have depression in one in AVL. That right there, it does not get any more STEMI than that. That is a perfect picture of a right-sided MI, or an inferior STEMI.
Rudy, so if you only had elevation lead 2 and then still had depression and one in AVL, could you still call that STEMI? Or
that's one of those instances where you can't definitively say it's a STEMI, but you can call the hospital and tell them what you got and let them make that determination. Because many times as a paramedic, and when in doubt, call a STEMI. Because the hospital will cancel it if they don't think it's a STEMI if you transmit it, or if you like send it over Pulsar or something like that. The cardiologist might take a look at it and be like, that's not a STEMI. Or the ER doc might look at it and be like, no, that's not a STEMI. It's an imposter of a STEMI. There's nothing wrong with that. During my career, I'm wrong all the time when it comes to STEMIs, but I know what to look for when it comes to them. Generally, you're going to have to call a STEMI. You generally have to have 2 leads of elevation that are contiguous. So 2 leads of elevation that look at the same part of the heart, generally, for STEMI protocols. But again, that might be a patient where if I see elevation developing in one lead, I check 5 minutes later to see if there's elevation developing in the other contiguous leads. Somebody doesn't have to have ST elevation to be having a heart attack. They can have what's called an N-STEMI or a non-STEMI, where their 12 lead looks completely fine. There's nothing wrong with it at all. But yet this patient is still pale, they're still diaphoretic, they're tachycardic, they're complaining of 10 out of 10 chest pain, and they're still having STEMI. Although a lot more rare than what you see here, it can happen. That answer your question?
yeah, thank you.
Yep. And we're going to do some more practices, so don't feel like I'm leaving you high and dry there. Again, limb leads, 1, 2, 3, AVR, AVL. Those are limb leads. Those are literally the 4 leads that we put on patients, right? When we put our precordial leads, we are putting the chest leads, V1 through V6. Does anybody know where V1 and V2 are supposed to properly be placed at?
Is it the first intercostal space? Let's see.
4th intercostal space on either side of the sternum. That is proper placement of V1 and V2. Most of the time we eyeball it and put them on, but proper placement is 4th intercostal space for V1 and V2. V4 is 5th intercostal space, as well as V5 and V6. Again, I cannot stress this enough, how important it is for us to know that these are contiguous, that 1 and AVL are contiguous along with V5 and V6, V3 and V4 are contiguous. V1 and V2, and 2, 3, and AVF. They're what we call like leads. They look at the same thing. But again, I have to have at least 2 leads showing the same thing to call a STEMI in a patient. Now, do I have to have depression to call a STEMI? Absolutely not. If I have elevation, I can call STEMI as well. But like next week, I will teach you guys about STEMI imposters. Things that can look like a STEMI but aren't, and how to determine if they are or aren't. Okay, so what part of the heart are these looking at? And this is really hard for people to memorize, and I don't expect you to memorize this. But if you can, bonus points to you. It'll help you out in the long run. So looking at our picture on the left, see that purple marked out part? That is V1 and V2. That is what we're looking at. That is your septal view of the heart. Essentially looking at the heart straight from the bottom, straight up towards the top. Now, if I was to say which coronary artery am I looking at, which artery do you think it's looking at the most?
Anterior descending.
Yeah, left anterior descending, LAD. Okay, good job. If I look at that middle picture with the orange leads, that is my anterior view. Which artery is that looking at? Pretty much the same, right? Pretty much our LAD. So sometimes when we see elevation V1 and V2, it can carry over into V3 and V4 because they are looking very closely at almost the same. 2, 3, and AVF. Look at our right side of our heart. And that is going to be our
Right.
Yep, RCA, right coronary artery. One AVL, V5, and V6. Look at the heart laterally, so from the side. Which artery is branches off of the left and goes around the back goes around the side like that?
Pulmonary.
Nope.
Circumflex?
Circumflex.
Circumflex, there you go. Left circumflex, remember, because it goes in a circle, so it circles around the heart, circumflex. When we talk about inferior wall MIs, it's very important that we consider those right-sided MIs. Now, have you guys ever heard or seen in your protocols that we have to be careful giving nitro to a patient having a right-sided MI? Has anybody ever heard that before?
Yes.
And maybe I've said it. Why do we have to be careful of giving nitro to a right-sided MI?
Decreases preload.
Okay, let me draw a heart out here for you. I'll break it up into 4 chambers. Okay, so I've got my 2 atriums, my left and right. I've got my 2 ventricles, my right and left. So blood comes into which side of the heart from the body?
Right. Atrium.
Okay, it comes into the right side, right? So that's where blood is returning to the heart. So blood drains into the right side. If I have the right side of the heart that is already having an infarct or is decreased blood flow, so the muscle isn't working like it should, and I give nitro, what happens to that blood vessel coming into the heart if I give nitro?
Does it shunt it back?
No.
No.
What happens to the vessel? What does nitro do to blood vessels?
Oh, it dilates.
it dilates. So I now took that vessel from what it looks like there, and I've made it this big. What does that do to the blood coming into the heart?
Triples the
Increases
load.
it.
It what?
Increases the load.
Nope. Because remember, the blood in the body didn't change, but the pipe size got bigger.
Well, it's going to be faster and stronger.
Nope.
No.
It decreases blood flow into the heart. Think, if I have, let's draw this here real quick. If I have a pipe that's this small and it's halfway full of fluid, no big deal. If I give nitro and I make that pipe this big, did I add any more fluid?
No, he just made it bigger.
I just made the pipe bigger. So which means there's only this much fluid in it now. I'm
Yeah, I
reducing
was thinking the
preload into the
opposite.
right side of the heart. So a concern with that is that we can bottom our patients out. We can bottom their blood pressure out because the right side of the heart is already having trouble. So we'd be very cautious when giving nitro in these patients. Generally, we want to see a systolic blood pressure above 90. And even at 90, I'd be a little nervous. 100, possibly. And, one of our medical directors, Dr. Poole, was very big on giving nitro in right-sided MIs. He says as long as we have IV access and we have a ability to give fluid, give nitro. Because your blood vessel has all that plaque buildup, right? So it's reducing how much blood is coming to the heart based off of plaque and blockages. If we vasodilate, we allow the blood to move past those blockages. But we're also giving more fluid to increase the amount of fluid in that pipe, is his theory behind it.
Rudy, I do
There's
have
some
one
patients
question
do what?
for you. I have one question. So if you're going to give that much fluid and you have plaque in there, isn't there like even a higher risk of stroke wise because the plaque's flooding loose, or no?
No, not necessarily. No.
Okay, that's what the question was. Sorry.
Nope, you're good. Some patients, it will bottom their pressure out. But again, if you have IV access, great. Other patients, it won't touch the blood pressure at all. It's really patient specific. So always maintain caution on right-sided MIs when giving nitro. That's why a lot of services are even looking at nitro drips, because it's a lot safer and it's over a longer period of time as opposed to a bolus of nitro like we give with a tablet or a sublingual spray. Example of an inferior wall MI. What leads do I have elevation?
Two AVF and lead 3. 2, 3
Okay.
AVF.
So these three leads right here, right? Typical of an inferior MI. What leads do I have depression?
V2 and AVL.
Okay, so I have depression in B2, I have depression in AVL. Yeah, I'd say that's major depression in those leads. I have minor amount right here in lead 1, and maybe a minor amount right here in V4. So I have elevation with reciprocal changes in lead 1, AVL, V2, and V4. I can confidently call a STEMI alert on this patient and say, without a doubt, they're having a right-sided MI. Questions so far? Okay, let's take a 5-minute break, come back, and I'm going to show you some other 12 leads having to do with MIs.
Hey, Rudy.
Yeah.
Do you see my email I sent you?
I have not checked my email since I left at like 4.
I have clinical tomorrow at Area and Sunday with Waterloo Fire.
Okay.
And I need you to cancel them because I tested positive for COVID today.
Okay. Do I need to let area know, or have you?
I didn't contact them because I didn't know if I was supposed to.
Okay. I'll reach out to him and let him know.
Okay.
All right, guys, we're going to go ahead and keep moving. We have some ground to cover here. All right, I need to know any questions so far. And if you're not paying attention, I feel for you. All right. So, inferior wall MI obviously looks at the right coronary artery. We have the opposite side, which is our lateral, again, which looks at our left circumflex. That's our artery here that wraps around. LCX is how it's abbreviated, left circumflex. Here we are looking at leads 1 AVL, V5, and V6 for potential LCX involvement. How the camera view is essentially looking at that. Okay, let's take a look at this 12 lead. Again, let's start in lead 1 and work our way down. Call something out if you see it in a specific lead.
I see elevation in 1, AVL, and V6.
Okay, so I'm going to put an E where you said you see elevation. 1, AVL, you said V6. All right, anybody, who else sees elevation somewhere else?
I'm sorry, also V5. Sorry.
And V2, and V3, and V4. And then depression in 3. And yeah.
Okay. Wow, we've got a multitude of stuff going on here. So 1 AVL, V5, V6. Which part of the heart is that again?
Lateral.
Lateral side, right? Looking at the left circumflex. Okay, well, I've also got involvement of V2, V3, and V4, potentially, right? Because I see elevation there as well. 2, 3, and AVF are the only leads that look at the right side. So V2, V3, and V4, what do you think those look out as well, along with V5, V6, AVL, and 1?
I'm sorry, what was that?
The leads that all have E on them, which side of the heart do you think is having a potential infarct?
The lateral. And inferior?
Nope.
Interior.
Okay. So I could classify this anterior and lateral because I've got V2, V3, V4. What I would call this is an anterolateral MI because I have interior involvement as well as lateral. I don't have a lot of depression around. I might have a slight amount here in AVF, but okay, my elevation or my injury is on the left side of the heart. Can you guys agree with that?
Yeah.
And my depression is on which side of the heart?
Right.
Right.
Right. I'll generally always see depression or elevation opposite in the opposite leads, in the opposite side of the heart. That's our reciprocal change. So I could definitively with this as well say this patient is having an MI because I have depression on the right side of the heart and elevation on the left. Interior, again, V3, V4. Some people will throw V1 and V2 as interior as well. But us being a good paramedics room B, know that V1 and V2 can also be septal, right? Remember, they look at very much the similar parts of the heart. So let's look at an anterior wall MI. Start with lead 1 and work our way down. What do we see?
Elevation.
Okay, where?
There's slight elevation in L1, but I see elevation again in, let's see, V3 to V6 area. Well, V2 and V3.
Okay, so elevation in V2, elevation in V3. Anybody else? Anywhere else?
A slight elevation in 1. I can't really tell though.
VF.
Okay, so let's zoom in on AVF. Is there enough there to call it elevation?
Well, it's really hard to make a baseline there.
Okay. Let's do this. Let me draw best baseline as I can.
There,
No, zoom in on it.
there's
Is there
slight
enough?
elevation, but not much.
No, what you're seeing is a T wave, not elevation.
Okay.
Yeah, I see that now.
Okay. What about lead V4?
Yeah, there's elevation. There's
Maybe,
elevation.
yeah, maybe a millimeter. Okay, do I see depression anywhere?
Rudy, can you zoom back a little bit? Sorry.
Can I what? Sorry. What would you say?
Forget it. I fixed my screen. It's okay.
Do you see depression anywhere? Anybody?
I can't tell if 2 as.
AVR, and you're correct. But remember, AVR means nothing to us in 12 leads. So I don't even pay attention to AVR.
Say no depression.
I would agree with that. I don't see any depression, but I do have elevation. So again, I don't have any reciprocal change, but I would still call an MI on this. And I'd call it an anterior MI because my elevation is majority in V3 and V4. Both those leads are made up with elevation, slight elevation in V2, but I know that a lot of times in V2 we could potentially have elevation if we have it in V3 and V4 because how close those leads are to each other. I'd still call it a STEMI, even though there's no depression. Okay, the wall looks at V1 and V2. Start in lead 1, work our way down.
You have elevation in V1 and V2. Slight in 1, but V2 you have a little bit more.
Yeah, I completely agree with that. Slight in 1, but V2, absolutely. So elevation here, elevation here. Do we have depression anywhere?
I can't
V5,
tell.
V6?
V5, sorry.
Maybe not V5 so much.
Okay, not so much, right? Because if I draw this line, and sometimes it's hard to tell. Not really any depression there, right? And not really enough elevation to call anything. So I'd venture to say that V1 and V2 are my only leads where I see any abnormalities. So that would potentially be a septal wall MI. And that's what I would call it if I was to call this report in on this patient, because I do have elevation in leads V1 and V2. It is important for us to know which coronary artery is potentially involved because that could dictate our treatment, such as a right coronary artery. We know we need to be cautious with medications that can drop blood pressure. Nitroglycerin, morphine, fentanyl, those can all drop blood pressure, so we have to be very careful with those patients. Okay. Now, let me throw this at you with the inferior MI. If I have elevation in leads 2, 3, and AVF like I have here, normal 12 lead, right? To verify that it is truly a right-sided MI, does anybody know what I can do?
Place one of the leads on the back or
Nope, not the back. You're on the right track.
On the
We're
right
correct.
side.
Opposite.
Yeah, I put okay, so I take V4. Only lead V4. Only that sticker. Only that electrode. And I move it on the opposite side of the chest, exactly where it would be anatomically. Because I want V4 just to look at the right side. I will then run another 12 lead. When that one prints out, I take V4 and I relabel it V4R because it's reversed. And if I see elevation in V4, that is 100% definitive that I have a right-sided MI. That's what's called a right-sided 12 lead. Only move V4 over. You can move all your leads over and do the same thing, but for sake of time, on a patient that's potentially time sensitive, I only move V4 to look. And again, if you see elevation, indicative that is a 100%, 99%, nothing's 100% in EMS, 99% blockage of the right coronary artery. If it's not elevated, then it could potentially be some sort of other left coronary artery wrapping around the back.
So can you just repeat that quickly again? So
Yeah.
the V4 on the right would also be elevated?
Yep.
And the other one
Absolutely.
would be?
Yep. And your 2, 3, and AVF would be elevated. Yep. So literally, if I looked at my lead placement right here,
You know, another beautiful day at work. How are you?
I will take.
Yeah, it's cold outside. Hey, so
Hey,
John,
Shane, mute yourself real quick, Shane.
Hot mic dog.
Okay, I will take V4 if I'm looking at these leads right here on my chest. So 1, V1, V2, V3, V4. I will take that sticker and place it over here, or that electrode and place it over there. Just that electrode. And leave the other ones where they're at. And I only do that to confirm a right-sided MI.
I'm sorry to interrupt. I have a question, Rudy. So when you draw all these drawings, will this show up on your sheet when we
On my
do homework later, or no?
What do you mean?
Because when you're doing this on the PowerPoint right now and we're listening to it, will we
Mhm.
see this if we go back to review or no?
Yeah, you will.
Okay, I'm just trying to figure out because I'm like writing as fast as I can here.
Yeah, you will. Yep, it'll
Okay,
show up
thank
on the
you.
it'll show up
Awesome.
on the video.
Awesome. Thank you.
Let me go back to where I was at. Sorry. There's a reason I keep throwing in this in the slideshow, because it is very important we learn to memorize these different leads and what they're looking at. Even if you don't know which coronary artery, that's fine. But know which leads these are looking at. Again, reciprocal change. If I see elevation in 2 contiguous leads, then look for depression in opposite leads. So if I have elevation on my right side, if I have elevation in leads 2, 3, and AVF, then I want to look for depression in all my other leads. V1, AVL, V1, V2, V3, 4, 5, and 6. That is a reciprocal change when we see something opposite happen in the opposing leads. So let's look at my right side of my heart. Which leads am I looking at for right side?
Two, three AVF.
Okay, 2, 3, and AVF. So that's my right side. Now let's look at my left side for reciprocal changes. Where do I see those reciprocal changes at?
You have depression in AVL V2.
Okay, AVL, V2, maybe slightly in 1, but not a lot, right? Our ones that we really see is AVL and V2. So those are opposite leads. Those look at the left side of the heart. So when I mentioned what we're looking for, and this is what I really want you memorizing for this portion of class, or for this class itself, for this week, I want you looking for ST elevation, okay, of greater than 1 millimeter. I want you looking for that elevation in 2 contiguous leads, so alike leads. 2, 3, and AVF are like leads. 1 AVL, V5, and V6 are like leads. V3 and V4 are alike, and V1 and 2 are alike. So we'll just say alike leads. And then I want you looking for opposite changes. When I think of opposite changes, the easiest way for me to remember it is like the justice scale. Does anybody know what a justice scale is? Or I call it the justice scale, like a scientific scale. What happens if I put weight on one side of it? What happens to the other side?
It goes up. But
Yeah, it goes up. So where I have depression on one side, I'll generally see elevation in the other. If I was to draw a little scale here, that's my normal scale. Everything is even, right? If I put weight on one side, or if I have a blockage on one side, my scale tips. This is depression. This is elevation. Know where we are looking. And when I said earlier, you look where you see any issues, that's literally what I mean. And again, to start out reading 12 leads, I want you looking straight down at all your leads. Go 1, 2, 3. Go AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. I know with past students, and even with me when I was going through paramedic school, I bought a pocket reference card off of like Amazon. Don't do that. I have cards at the college that I can give you guys that will outline which leads look at what, and you can stick them on the back of your badge. It might help you out a little bit, especially when you're at the hospital, you're in a field clinical or whatever it might be, and you draw a blank. You can flip to that card really quickly and be like, oh yeah, this is the part of the heart it's looking at. And it will help you over time in paramedic school as well. It does take time, but through repetition, you will have it memorized. And that comes from constantly looking at 12 leads, constantly reviewing 12 leads. Now's the point where I will allow you guys to begin interpreting 12 leads. We're looking for elevation, right? We're looking for depression. There's one other thing I'm going to teach you guys as well tonight, and that is what a bundle branch block is and how to look for that. It is the easiest thing you can think of, People make it a lot harder than what it is. If you guys can do what we just went through a little with tonight with elevation, bundle branches are nothing to be afraid of. Okay, let's look at another strip here. Tanya, you've been calling out a lot of stuff. I got to give somebody else another chance. So let's say, Mr. Robinson, you better be listening.
Yes.
What do you see when we look at this 12 lead? And I'm not going to, if you get something wrong, this is where we learn. This is how we learn. I'd rather us make mistakes during this and in clinicals than when we become paramedics. So don't feel like you're under pressure.
I see elevation in 2 and 3.
Okay, so I'm going to write E for elevation.
I see it in AVF.
Okay.
Depression in V3, V6, V5, and V4.
Okay, so I'll put a D, V3, V6, V5, V4. Where else do you see depression?
It looks like there's some in AVL as well. And then segment 1. Or I'm sorry, number 1.
All right, now Nate, here's the real question. Who's telling you answers?
My team's not very quiet.
No, I can tell they're not.
Hey, I'm in this class too.
Okay, that counts.
Okay.
All right. So you were assisted by Blake.
Yes.
So
yeah, majority was me.
All right, Nate, and only Nate, what part of the heart does this look at where we see elevation? Look at the picture I had you take.
Yep, hold on. Your right side?
Yeah, right side. More specifically, what part of the right? Like what specifically?
Would it be the right interior?
Inferior.
Inferior.
Yep, inferior. So I would definitively call that a right-sided MI. I'd have, with all comfortability, based off depression that I'm seeing in opposite leads, have no problem calling that a right-sided STEMI, as long as I have elevation in excess of how many millimeters?
1.
Yeah, greater than 1 millimeter. Okay, good job. All right, let me pick somebody else, since I essentially knocked 2 of you out with one of those. Who else do I got here? Dakota, are you in this class by chance?
Yeah.
All right. Tell me what you see looking at this.
I've got elevation in V1, V2, V3, and V4.
Okay. Do you see depression anywhere?
Maybe a little bit in AVF.
Okay, that prompts me to look at what other leads when I see an AVF.
2 and 3.
There you go. Those are the alike leads for AVF, right? Okay. So I have elevation on which side of my heart?
On the left side.
Yep, and I have depression on which side? The opposite, right?
Right side. Yep.
So looking at this, what kind of MI could we call that? Because it's got septal and anterior involvement. And this is something new, so I don't expect you to pull it out of thin air. I could say that is anteroseptal. You wouldn't be wrong to just call it an anterior MI. But more specifically, since there's V1 and V2, I call it anteroseptal. Do you understand why, like how I called it that?
Yep.
Okay. So some of you are mistaking, again, what I call hyperacute T waves for elevation. I want you to look. A hyperacute T wave is essentially a tall T wave that's rounded. So if I was to draw a complex, do my QRS, and I have a tall tinted T wave like that, that is what I call a peak T wave. Not a peak T wave, sorry, hyperacute T wave. But in lead 2, so let's look for elevation. Let's follow baseline. Do I have elevation there? Let's see who's in my class. Hunter, you listening? Okay. How about Joel? What do you see?
I would say there's elevation.
Okay. How many millimeters would you say?
3.
Yeah, I'd say 3. I'd go with that because there's my J point, right? Yeah, I'd say 3 millimeters of elevation. Now let's look at V3 down here. Where's my J point? We change direction right about there. That's right on the line of 1 millimeter. That is more of a hyperacute T wave than it is elevation. But again, a hyperacute T wave will generally precede a STEMI, will precede ST elevation. So where you see those T waves like that, I'm guessing if you, in a minute or two, you'll probably see elevation in that lead. It'll progress to elevation. Now, when it comes to 12 lead monitoring of a patient, how often should we be performing a 12 lead during transport?
They're presenting what their MI showed, right? I mean, if they're critical, it'd be every 5 minutes. If they're stable, it's every 15.
Okay, so you're saying roughly 5 minutes critical, 15 if they're stable.
Yeah.
Now, what I like to do personally with 12 leads is I like to take serial 12 leads during transport. So I might take one every 3 to 4 minutes because I want to know if the treatments I'm doing are changing anything. I've literally had patients before. I do a 12 lead before I do a treatment because I want to identify it before I attack it with anything. I've had patients before that a drug such as minuscule as aspirin changed their 12 lead. So that's why I kind of like to know what animal I'm fighting before I essentially know how to attack it. And after each time I perform a treatment, I might wait a couple minutes and perform another 12 lead. But a good rule of thumb, when you initially get to the patient, perform one. After your treatments, perform one during transport, and perform one right when you get to the hospital. Because I like to show the hospital the latest 12 lead that I got. Just leave your cables on the patient. All you have to do is hit start in a 12 lead each time. And that will record in your monitor. And you can print those off later if you need to. Hunter, I got your message. I wasn't too worried about it. Okay. After we see those hyperacute T waves, again, it will most likely progress to ST elevation as seen here. Now, this one's kind of tricky because the J point is right here on these, right where we're changing directions. So if I had to say that's over baseline, How many millimeters of elevation is that over baseline? Would you say roughly?
Four.
Yeah, I'd say 4 millimeters of elevation over baseline. Have you guys ever heard the term tombstone when somebody's referring to a 12 lead?
Yeah, it's usually not good.
When they talk about tombstones, this is what they're talking about, these hyperacute T waves. Again, a normal 12 lead does not rule out that our patient is truly having an MI. We can have non-STEMIs. We can have patients that are having STEMIs but not showing them on a 12 lead. I know that sounds crazy, but it can happen. Patient, if it walks like a duck, talks like a duck, treat it like a duck. If somebody's having chest pain, we follow ACS protocol, acute coronary syndrome protocol. When it comes to this, when it comes to chest pain for a medical emergency, what's the first medication we generally give our patients?
Aspirin.
Okay, so ASA, what dose do we usually give them?
324.
Did you say, what'd you say, sorry?
324.
Okay. What's our next drug?
Nitro.
Nitro.
Okay, how much is in each spray or each tablet?
0.4.
0.4 milligrams, right? Okay. What could be our next drug of choice for pain management wise?
Morphine.
Okay, morphine is a great drug for cardiac pain. I love morphine for cardiac. But again, what's a concern with morphine and blood pressure?
It'll drop your blood pressure.
Could potentially drop blood pressure. Dose for morphine for chest pain, I'd say 1 to 2 milligrams. Okay. What about fentanyl? Can we give fentanyl for chest pain?
Yeah.
Yeah, absolutely. Generally, some protocols will say 50 to 100, or some will say 1 microgram per kilogram. Again, after we perform a treatment, do another 12 lead. Make sure nothing's changed with your patient. All right, let me think of who else we got in this class. Spencer, are you listening? Maybe. Okay.
Can you hear him?
Yeah, I can hear you.
He's trying to figure out his computer.
All right.
All right, I got him here for you.
Okay.
Go ahead.
All right. What do you see when we're looking at this 12 lead? Tell me where you see elevation. Tell me where you see depression.
Working. Oh, yeah, turn your volume on. There we go. Go again, Rudy.
Tell me where you see elevation and where you see depression on this.
V3, V2, V1, V4.
Okay.
And 5, V5.
Okay. Now, do you see depression anywhere?
Maybe 2 and 3.
maybe 2 and 3. Not a whole lot there to call though, right?
No, not really.
Okay, so we'll just, yeah, not really, but I can see it maybe starting in there, but there's not enough for me to call. So those leads that you mentioned, what part of the heart is that? Left or right side?
Left.
Okay. Looking at that picture that I had you guys all take a picture of, what part of the heart are those leads referring to?
Mostly anterior septal.
Yeah, I would 100% agree with that. Aneroceptal as well. Okay. All right, let's take a look at another one here. Let's see what we're looking at. Pretty much the same 12 lead. Yeah, I'm going to see if there's another one here. All right. Sarah, you listening?
Yep.
All right. Call out what you see.
I see elevation in 2, 3. AVF.
Okay. Anywhere else?
One just looks sketchy. It looks weird.
It looks a little sketchy. Maybe some depression there, right?
Yeah.
Okay. So where am I seeing all depression at? Call out those leads.
Yeah, I'd say 1 AVL.
Okay. So D.
2. I don't know.
You're on the right track.
2 and 3.
Okay. There's one more. Well, kind of one more, I guess. We'll go with what you got.
What one were you seeing?
I was going to say V4 because the first complex showed depression, but the second one doesn't.
Oh,
really.
right. Yeah, the second one doesn't, but yeah, the first one does.
Okay. So which side of my heart is potentially having the infarct?
That would be the right side.
Okay. And where are we seeing depression or ischemia at?
That would be, let's see. Part of the lateral, septal, and anterior.
Okay.
So the left side.
Good. Perfect. Now, which lead could I move over if I wanted to confirm a right-sided?
V4.
Okay. And then what would I relabel that on my 12 lead?
Is it V4R?
Yep, exactly that. V4R. Perfect. Good job. Again, I am beating a dead horse with this, but I'm trying to get it ingrained in your guys' head, and if I have to do that by force, I will. Where I see elevation on this side, I will probably see depression on the other side. That is what a reciprocal change is. There's my scale. Shane, what do we have here?
Looks like elevation in 2, 3. AVF.
Okay. Boy, does it seem like we're looking a lot of right-sided 12 leads. There's a reason for that, and that's because a lot of the STEMIs we will see are right-sided STEMIs. There's a reason I want you guys to get in the habit of looking at these. Where do we see depression at?
I've got 1 AVL.
Okay. So can I call that a STEMI?
Yeah.
Yeah, I would agree. No issues there for me. I'm trying to think of people in this class. Who wants to speak up? Because I can't see anybody's names right now when I'm sharing. Oh, I see how it's going to be. Alex Fulton, tell me what you see.
V2 and V3
V2, V3 what?
elevation of V4.
Okay. Where do I see depression?
AVF.
This is a scary one. Okay, AVF.
Lead 3 and lead 2.
Okay. Would everybody agree with that, or do we see elevation somewhere else too?
V5.
Okay. Maybe a tiny amount, maybe not enough to call in V5.
Okay, sorry.
V1.
Okay, I would go with that. V1. Where else?
1 in AVL.
1 in AVL. So that almost seems like I have lateral involvement, I have anterior involvement, and I have septal involvement, right? Would everybody agree with that?
Yes.
So that's the whole left side of my heart. That's every artery on the left side of my heart, right?
Yep.
Okay, so let's call this something.
The Widowmaker.
When I have total, I wouldn't say occlusion because I can't tell if it's total occlusion or not, but when I have involvement of every essentially part of my left side, it is what's called a widowmaker, or also like a like 3-vessel disease. That is a blockage right above my left circumflex at my left main. There's no blood going to my left anterior descending. There's no blood going around the back to my left circumflex. That is a bad deal right there. So when you see elevation in all your left-sided leads in depression in your right, that is a really good indicator that this is a widowmaker. Who's heard of a widowmaker before?
Me.
Okay. And again, the reason I called it 3-vessel disease is left main involvement, left circumflex involvement, and left anterior descending involvement.
What would you call that into the hospital as?
I would honestly call it in and tell them what it is. I have elevation throughout my lateral, or throughout my precordial leads, and I have depression on the right side of my heart. That right there should tell them enough. You can also tell them, I think this patients potentially have a widowmaker. I have elevation in leads 1 AVL, V1 through V4. And again, with depression in 2, 3, and AVF. They should know enough that that's what that means. If you use Pulsera and you take a picture of this, they're probably going to keep this as a STEMI alert. Time is muscle when it comes to these patients. It's fine that we can give them these medications, we can do these 12 leads, but do not let any of the treatments that you're performing or any of your assessment tools get in the way of rapid transport when it comes to these patients. They need a cardiac stent. They need a cath lab. They need opened up. These are the patients that if you give a good report and there's truly a STEMI and you give that STEMI alert, you're probably bypassing the ER and going straight to the cath lab. But giving them a good heads up allows them to get the cath lab up and going. For some services, if you're maybe bypassing a smaller hospital and going up to the Des Moines Metro or coming to the Des Moines Metro, your protocols might even say you're going to give this patient heparin. And that's to essentially thin the clot out and thin the blood. Generally, the dose for heparin is 4,000 units. Again, we don't have to have reciprocal changes to call an MI. It's a really good indicator. It helps our case, but we don't have to have it. But when I'm confirming an MI, having those reciprocal changes helps me make that decision a little bit easier, that this patient is truly having an MI. Who else do I have in this class? Who hasn't gone yet and said something?
I can give it a go.
Okay, who is it? Is this Alex?
Did you hear me?
Yeah, who is this?
This is Scott Watson.
Okay, Scott, sorry. I got you and Alex confused.
Oh, you're good. We're just having some technical issues over here.
No, you're fine. All right, tell me what you see.
Okay, I got elevation in V2, V3, V4, V5.
Okay, so E. Not so much in V5. Let's draw that line straight across. When in doubt, draw the line. Close, but I wouldn't call it elevation yet.
Okay. Oh, I see. Yep.
Okay. So what part of the heart would that be?
That'd be the lateral.
What part?
Or anterior.
There you go. Thought I heard you wrong. Just want to make sure. Perfect. Now, there are imitators or imposters of infarct. I'm going to go over one of the imposters tonight. And believe it or not, this right here is an imposter. This isn't a STEMI. And I'm going to show you why.
Hyperkalemia? Sorry.
Do what?
Is it hyperkalemia?
Nope.
Nope.
Okay, so the one we're going to cover tonight is bundle branch blocks. So let's look at this. To be considered a bundle branch block, my QRS duration has to be over 0.12. My normal duration is 0.08 to 0.12. Okay, so 0.08 to 0.12. So I have to have a wide QRS. So a lot of times that'll look like such because it's wide, or it could look like such. It's just a wide QRS. But it will generally only be wide in lead V1. So I want you to pay attention only to V1 when we're looking at this. Okay, look at, again, just this lead. Do you think that QRS duration is within 0.08 or wide or narrower? Let me zoom in on this. I'll count the boxes because it might be hard for you guys to see. I've got 5 small boxes. What does that make my width?
0.2.
0.2.
Okay. So in V1, it's wide. All my other leads look kind of messed up. But here's how I tell what's going on. That is what's called a bundle branch block. And it means that there is a blockage in one of my bundle branches, right? So it delays conduction. When conduction gets delayed, it takes more time to get through. Remember, those blocks, those small boxes, equal time as well. So it's taking a little bit longer time to get through. Let me see if I can find, oh, no, of course not. Okay, so easy tip. In V1, let me pull my pen back out. If, let's find baseline, let's make a baseline here. If my complex is mostly above baseline, it is a right bundle branch block. If it is mostly below baseline, it is a left bundle branch block. The way I figure that out is, I'm going to switch my color here because it's going to be easier to show you. If I'm driving backwards down my baseline here, and I come to this stop, which way do I have to turn at that stop?
Right.
I have to turn right. It's the same concept here. Coming down, which way do I have to turn when I get to the end?
Left.
No.
Oh, right,
There's
sorry.
There's no line going left, only to the right. Okay, so let's look at a different one. Look at V1. Its width is about 0.16, so it's wider than normal. I'm coming, I go over the hill. Which way do I have to turn at my QRS complex?
Left.
I have to turn left, so that's a left bundle branch block. Anytime, and they call that the turn signal method. So remember, if I'm driving down this complex and I come up to this, I have to turn left here. I can't go right. There's no complex going up. That is a left bundle branch block. As opposed to if I'm coming down here and I come up to this, I have to turn right because that is a right bundle branch block. See that? I have to go in this direction. As opposed to here, I have to go in that direction.
So you look at it backwards, like you
Yep,
you look
like
at
you're
it
driving down. Yep, like you're driving down backwards.
Okay.
I always remember bunny ears to the right is a right bundle band, down the left is left bundle band. I don't know.
Don't
just
pay
bunny
attention
ears.
to the bunny ears though, because you will not always have those. You could just have a wide rhythm, like 'cause this one right here. There's no bunny ears on that one. A lot of people will pay attention to the bunny ears, but it's not always definitive. And again, this is stuff we're going to be practicing in lab and going over, so please don't feel like this is the only time we're going to look at it. What I want you to remember, left bundle branch goes negative, right bundle branch goes positive. If the QRS is mostly positive, it's a right. If the QRS is mostly negative, it's a left. And it has to be over 0.12 to be considered a bundle branch block. And we only pay attention to lead V1. Who's confused on that? Because I know there's somebody.
Okay.
Good. Now
Question.
that I know you're going
Good
down
now.
the wrong side of the road.
Yeah, sorry, you're driving backwards.
That's how we always drive.
When it comes to looking at a 12 lead, you guys will find out your own rhythm. You guys will find your own methodical way of looking at them. Again, I look at them diagonally. I start at lead 1 and travel down to lead V6. But how I want you guys starting is going straight down each column until you see something worth mentioning. Does that make sense?
Yes.
Now, as far as clinicals go, I am going to, there are 2 clinical sites that you guys have not been to yet. And I will open up probably next week or the week after. I will send you guys an email when I do. It is the cath lab and the cardiac cath lab. What you deal with in there is looking at blocked vessels. You look at angiograms. You watch them perform an angiogram on patients that are coming in with blocked vessels. You get to see the blockage in real time in a 3D diagram. It is one of the coolest things to be able to talk to cardiologists, and they love having paramedic students because they want you guys to be able to identify these really easily. They are great people to ask questions to. They welcome that. They would love to have all the sorts of questions asked to them. So when I open those up, you again only have to do 1 rotation in each one. There's no set specific hours you have to be, or no minimum requirement. You just have to do 1 8-hour shift in each department, cardiac cath lab and cath lab recovery. Cath lab recovery is where you will be able to see patients get paced, and you will be able to see patients get cardioverted. It is a good experience in both those clinical disciplines. And again, if you see something interesting, I probably went to the cath lab 4 or 5 times because I really enjoyed looking at hearts and looking how they function and watching them put the dye in, and you get to watch the dye in real time on the monitor go through, and you get to see which vessel's blocked because the dye can't move past the block. It's really neat. And then you watch them place the cardiac stent, and you watch the vessel open up. It is really cool to be able to watch. All right. As far as tonight, again, I don't want you guys to feel like super lost. I know we covered believe it or not, we covered a lot of stuff. Next week, we're going to go over some more imposters with 12 leads. We're going to look at other things that can mimic STEMIs. Generally, in the presence of a bundle branch block, you will have what looks to be elevation. Let me pull that last slide back up that we called it elevation. That is a wide QRS. Or wait, where'd it go? No, not that one. This one. Look at V1. Let's say it, gosh darn it. Let's say it's 0.16 wide. Is that a left or right bundle branch?
Left.
That is a left, absolutely. In the presence of a bundle branch block, you can have elevation, but it is not a true STEMI. It is an imposter. That's why you don't see any depression anywhere.
Question.
Mm-hmm.
I had a incomplete right bundle block, or bundle branch block. What defines that? Because I'm looking at the strip and it's like, I don't see it in V1.
What that means in V1 is that you were like right on the edge of 0.12. You weren't above the 0.12. You were right at the edge, so they call it an incomplete bundle.
Okay.
So my question, so if it's going down, it's usually going to be a left. If it's going up, it's going to be a right, correct?
Correct. And let me find a picture that will portray that a little bit better real quick. You guys can still see my screen, right?
Yep.
Okay, if you can still see that, look at V1 alone. Don't pay attention to that V6. See how on the RBBB, the right bundle branch block, if you're driving down the road backwards, you have to turn right because it's positive. As opposed to the left bundle branch block, if you're driving down the road, you got to turn left because it's negative in V1. And if you need to take a picture of that, by all means, hang on to that as well. Bundle branch blocks are really common to see in EMS. And again, your patients can present with like a new onset of syncope, dizziness. Maybe they feel like they're going to pass out. That could be to a new bundle branch block. Just delayed conduction. So the beat just takes a little bit longer to get through their heart. And now I expect everybody to, and I'm not saying you have to, but I imagine everybody will start looking at 12 leads of ST elevation and looking at what they see, and 12 leads of bundle branch blocks, which I welcome that. By all means, go for it. Start paying a little more attention to your 12 leads when you're doing ride time at this point. Ask the people that you're riding with. Ask your preceptors what they see. A lot of nurses don't look for ST elevation or depression. That's what the doctor does. So you can ask the nurse. There's nothing wrong with that, because some of them are trained in it. A lot of them aren't. But ask the doctor as well, especially if there's a cardiologist around. Ask them what they see on a 12 lead. All right, question time. What questions can I answer for anybody? I know there's probably a lot. And again, we are covering this the rest of your guys' paramedic education, so don't feel like this is the last time you will see this. This is just the first time us bringing it up.
I guess so when you say that the it's an imitator of an infarct with those qualities of a QRS, wide QRS, and only paying attention to V1. So it's only going to show in V1 is what you're saying.
Yes. That's the only place I want us looking for it is V1.
Okay.
Any other questions, folks? Again, I could go on and probably make this class last till 10 and bring up all the imposters, but what are you really going to retain? I want you retaining right now ST elevation, ST depression, looking at different types of leads, looking at your anterior, looking at your lateral, looking at your septal, looking at your left side versus your right, looking for reciprocal changes of elevation versus depression. That is what I want you guys focusing on. We will continue to cover bundle branches, so don't worry so much about that, but that was just kind of an intro to them. And we're going to cover them again next week, along with some other imposters of 12 leads and some other abnormalities that we can see on a 12 lead, such as electrolyte imbalances. So right now, we focus on ST elevation, depression, and then leads of the heart. All right. Does anybody feel like they got an okay understanding of that? I just need to base where I go with the next class. If I need to do a review, if I need to.
I feel way better about it. This is Cassie.
Okay, perfect. I forgot you were in here. I'd have called you out. Now some of this stuff might actually make sense when you're looking at 12 leads in the ER, when you're looking at 12 leads in the field. What I want you to also start doing is interpreting these 12 leads. So that's still a sinus rhythm, right? But it just has elevation. So I want you documenting these in FISDAP now. I want you taking pictures of these 12 leads and interpreting them. That's one of your competencies. If you can in the ER, ask for a copy of the 12 lead or ask to take a picture of it. They'll generally black out the patient's information for you so you can take a picture. Just make sure you do, or you cut that portion off and you're not uploading it with patient information on it. But now's the point where we begin to interpret 12 leads. Now's the point where you can send me 12 leads and I can help you guys read through them as well. Bring me rhythm strips. If you have strips that you want me to help you out with, send them to me in email, bring them to me in person, by all means. I love looking at 12 leads. I love hearts. If you guys don't have any further questions, I'm going to let you guys go tonight. Again, I don't want to overwhelm you, and I was kind of going through it fairly slow. Believe it or not, we're covering a majority of what cardiology is about. We still got to go through the medical emergencies portion of cardiology, but that's very minute compared to what we're going through now. The stuff that I'm having you guys go over, I feel like is very important and pertinent to your education as a paramedic, and I feel will really help you in the long run. And I expect you to talk to your other fellow paramedics that you work with and fellow coworkers and ask them about 12 leads. Have them bring up random strips. I have a book of 12 leads in my office of patients that I've done a 12 leads on. I keep almost all my 12 leads I've ever performed. So I have a pretty thick binder of them just to go through and show people different aspects of the heart and different types of heart attacks or different types of imposters. So if you ever want to see that, let me know and I can pull that out as well. If nothing else, I hope you guys have a great night. Please email me with questions. Please email me with any concerns, anything that you have, 12 leads, whatever it might be. I will help you to the fullest extent. And then next week, expect more cardiology. It's what we're going to continue to go over for next 2 weeks, I believe, next 2 to 3 weeks. I did make a mistake on my syllabus. I just wanted to point out, I have our final the week of the 12th. That's incorrect. The final is actually the week after that. So you guys actually have an extra week that we can add in and do whatever you guys want. And I'll leave that up to you once we get to the end of what I have for you with cardiology. If you want us to add another week of cardiology, we can. Or if you want us to put it towards maybe a night where you don't have class, that it's a free night for you guys, I'm open for whatever you guys want. But with that, everybody has to have an understanding if that's what you guys agree on. But again, I'm open for whatever. You guys are the students. You're the ones whose education is on the line here. So I want to be able to give you the best possible amount of education I can, the best possible amount of information that I can. Otherwise, have a good night. I will see some of you in Skills Lab, and otherwise, I will talk to you guys next Tuesday night.
Thank you.
Thanks, Rudy.
Thank you.
Rudy, is there anything else you need from me for missing clinical in class this Thursday? Like, do you need a copy of my actual COVID test or?
No, I'll send an email to Cheryl, just letting her know as well.
I sent it to you and her just to let you both know.
Okay.
And then with me being sick, missing the 2 clinical days and Thursday, does that count as part of my 10 days? Like we get off?
I don't believe COVID does. No, I don't believe we're counting that towards your 10 days.
All right, cool. Thanks, man.
Yep.